Good afternoon. Welcome to today's Wisconsin Health News Newsmaker event. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thank you all for tuning in. Thank you to our esteemed panelists for being here. I am thrilled to introduce Paul Nobile, president of Anthem Blue Cross and Blue Shield of Wisconsin, Krista Hoglund, interim CEO at Security Health Plan, Les McPhearson, president at Dean Health Plan, and Vaughn Vance, incoming CEO of WHN Insurance Corporation and Health Tradition Health Plan. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News Newsmaker series. These important discussions would not be possible without their support. So a huge thank you to Anthem Blue Cross and Blue Shield of Wisconsin, Deloitte, Froedtert and the Medical College of Wisconsin, Husch Blackwell, UnitedHealthcare Community Plan, Briesen Roper, and the Wisconsin Hospital Association. Thank you also to Badger Bay Management for hosting today's event in partnership with Wisconsin Health News. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up on our website at wisconsinhealthnews.com or through the event evaluation form, which we'll email out after today's event. And an extra thanks today to UnitedHealthcare Community Plan, today's featured sponsor. We are so grateful for all their generous support. And here to say a few words today is CEO Kevin Moore.
Hey, Tim, thanks a lot. Hello, everybody. I'm Kevin Moore. I'm the CEO of our UnitedHealthcare Community Plan here in Wisconsin. It's really great to be with all of you today virtually. I know eventually, I like to say we'll get back to seeing people in 3 dimensions as opposed to 2 dimensions. But as Tim said, we're really excited about being part of this roundtable discussion and sponsoring this conversation. At UnitedHealthcare Community Plan, along with our partners over on our commercial side as well as our Medicare side, our focus is really to help people live healthier lives and make sure that the healthcare system is working better for everyone. And we do this by working together as a community. And this is really part of what makes us unique, particularly in Wisconsin, is our willingness to understand that community partnerships are really core to making our partnerships in our healthcare system work better, but really for our members and our families and our communities. UnitedHealthcare, it's a fundamental belief that every person should have an opportunity to pursue the optimal health, regardless of their age, regardless of skin color, regardless of level of education, gender identity, sexual orientation, job status, or where they live, or if they have a disability. And during the pandemic, we've seen some of the health disparities that we knew existed really become magnified. And this is one of the areas that I think we're really excited to listen to some of the ideas moving into 2022, because we're all in the same boat when it comes to addressing and mitigating disparities for our populations. I say that knowing, though, that Wisconsin, we're very proud of some of the strides that we've made. According to our most recent America's Health rankings, we've seen that some areas have decreased. We've seen things like preventable hospitalizations decrease, and that we've seen smoking decrease here in the state. But the challenge is COVID made some of these gains negated, and we have other areas to work on, particularly around behavioral health, maternal child health outcomes. And when you overlay disparities on all of that, we really have a laser focus that we all need to be put our attention to make sure that our communities are better and healthier. Now, as we get ready to turn the corner into a new year, I really look forward to working with members, providers, plans, patients, and our state and federal partners to really find sustainable and scalable solutions that improve the health and well-being of our communities while addressing the health inequities and disparities that we all know are barriers to good health. Now, for me personally, I'm eager to hear from our colleagues and partners today. We've got a great panel of ideas, people with experience in this field, but really understanding what the last 18 months to 2 years has done as COVID has impacted our state, and looking forward to where they see the opportunities to address some of the biggest issues facing our families. So again, thank you, Tim. Thank you, Wisconsin Health News. Thank you, panelists, for being part of this very important conversation. And I wish everybody a really great afternoon. Tim, back to you.
Excellent. Kevin, thank you so much. Thanks for the kind words. Thanks for giving us kind of a good starting point for today's discussion. And thanks to UnitedHealthcare Community Plan for all of your generous support. And thank you also to our insurance leaders again for being here today. We have a lot to talk about, so I am just going to dive into the questions. And Les, let's start with you. So we are still in the midst of a global pandemic. What has COVID-19 meant for Dean Health Plan? I mean, in terms of utilization, how do things stand now compared to before COVID-19?
Sure. Well, thank you, Tim, and it's a pleasure to join everyone today. It's been a remarkable experience for Dean Health Plan, as it has been for all of us. Financially and operationally, we remain strong. We've come through the pandemic to this point, solid in terms of economic performance, and operationally continuing to serve our members, employer clients, provider partners, and brokers. We look at financial results holistically as an integrated delivery system, and like many health plans, we emerged from or have come to this point through the pandemic in fairly solid footing financially. But of course, as part of a health system, and as most health systems across the country, the pandemic placed unprecedented financial stress on healthcare delivery, including SSM Health. So we've navigated that quite well and feel good about where we are in position for the future. In terms of utilization, we have seen, for the most part, the volume of care return to what it was pre-pandemic. Some of that has been driven over the last 6 to 9 months with increased comfort by people coming into clinic settings, coming into hospital settings, and being in person. But of course, a lot of that has also come through increased confidence and reliability on telehealth. I'm hopeful that once this most recent and hopefully last surge is behind us, we'll see a return to a more pre-pandemic steady state. We feel good that for the most part, our members have been getting their cancer screenings, childhood immunizations, and other preventative care. And I believe we'll see that more of a quote unquote normal state in terms of chronic care management and non-emergent procedures once things start to settle down. But where we are today in terms of utilization and our provider partners in delivering care is pretty close to what things were before the pandemic began.
Great, thanks, Les. And telehealth is among the things I'm hoping that we can talk about a little bit more later in the program. Paul, what are you seeing at Anthem? I mean, have you seen any noticeable drop these past couple months as COVID-19 cases have surged again in Wisconsin?
Yeah, thanks, Tim. And Les, some of the comments that you made, I'll echo a little bit of that. We're seeing similar, some utilization patterns. You've heard the term, dips and surges in different settings. And, going back to even 2020, we saw dips in those electives, obviously, early on when we knew less about COVID-19. I think one of the benefits of being a Wisconsinite is the fact that the provider systems themselves are extremely agile. They organize, very effectively. Tim, you covered a lot of that early on with Dr. Raymond and others. And so we reacted exceptionally well compared to, some of what we've seen in other parts of the country. The dips in some of the utilization relative to the electives has settled down. And in fact, Wisconsin actually came back to more, kind of normalized levels much quicker than we saw in other areas of the country, frankly. We view that, and I said it over a year ago, we view that as a positive thing. I think Les alluded to the fact that we need to have people feel comfortable to come in to see their doctor, in particular on primary care. There was concern early on relative to, cancer screenings and the like, and making sure people were having continuity of care to the level that they needed. A lot of that is on site, whether it's primary or otherwise. So I think we're happy to see, at least in our data, that we are, at pre-pandemic levels relative to those utilization. From a cost perspective, there is cost relative to not only normal utilization, but also the cost of testing, diagnosis, and treatment of COVID patients themselves. Again, I think the health systems in Wisconsin have done a tremendous job on that. And we have seen, in the spikes, it has created some concern, in particular in certain parts of the states relative to ICU beds and, making sure there's capacity for care for other types of acute services. And, so I think we've worked, and you reported on this, Tim, as well, as far as, getting skilled nursing available and beds available for people to transfer out of hospital ICUs and free up those resources for people that need them for other types of services, or frankly, for other, COVID patients. So I think overall, there's dips and there's ebbs and flows and dips and spikes in this, but overall, we're back at pre-pandemic levels in overall utilization. We'll continue to watch the trends closely, but that's kind of where we sit today.
Thanks, Paul. Vaughn, how has WA Trust fared throughout this? I mean, what's been the financial impact for your plan?
Yeah, I think that COVID generally disrupted the predictability, seasonality of claims. And so we saw what everyone else did when people stopped going in to see their doctor for a time being. And like the other speakers, we've seen utilization return back to normal or more predictable with the addition of COVID specific costs. And they're real. They add to the cost of healthcare like everything else. And when you're not expecting it, unpredictable costs aren't really welcome in the insurance industry or anywhere else. So we had to adjust like everyone else. I think in terms of COVID, though, the disruption for us, you can tell I'm still at home. We're 100% remote. And from an operational perspective, that puts some additional strain on the organization to get out of the office as quickly as we could for our employees. What we've discovered is a change in business that's really working well for us and our members. So we remain 100% remote with services continuing, claims being paid. And getting back to a sense of new normal, not just from a utilization perspective, but how we do the work and how we've reimagined meeting the needs of our participants.
Going forward, what do you think, Vaughn, going forward, what do you think the impact of long COVID will be on cost? I mean, is that something that you guys have started tracking yet?
Well, it's certainly something that we are aware of, concerned about, and want to be able to assess. If I had the answer to it, I probably switch jobs and be an actuary, but I don't. It's certainly something that we do our best to sift through the data we have to figure out what we know, what we don't know, and what we can best guess. It's clearly going to be additional cost, but at this point, I don't have a benchmark for what we think that might be.
Krista, what are some of the lessons that security has learned the past 20 months? I mean, what are some of the changes that you've made as a health plan that will outlast this pandemic? Or at least outlast the worst of the pandemic?
Yeah, definitely the workforce comments that Vaughn just made are probably the biggest thing. 18, 19 months ago, early March, we had, no concept of, the ability of certain departments to work from home. We had a sort of a very, old school mindset about everybody needs to come into the office every day. That's the only way we can do our work. And what we found is that wasn't the case. And so that gives us tremendous opportunity to recruit, right, in a way that was very different from the past, but also our employees can be recruited in ways that they couldn't in the past. So, thinking about how do we keep our employees engaged in a virtual environment, which is going to be very different from in person. How do we keep the culture, very sort of community, focused? We really care about each other. This feeling that you got when you walked in the building. People don't have that anymore because they're not coming in, and so we have to think about differently about how we get and sort of retain that level of employee engagement. So I would say that's the biggest change for us. I think we also improved on our systemness. So we're part of an integrated health system, but when the call goes out because you're running short on staff on the care delivery side, and you've got your health plan employees volunteering to do shifts, that's sort of a tremendous integrating force that just wasn't there in the past. So I think that's going to continue, that we're going to be sort of closer connected with the rest of our integrated delivery system, just having sort of weathered this pandemic together.
Great. Thank you, Krista. Les, you mentioned, as you mentioned, a big change in the way that healthcare is delivered since the pandemic began is increased use of telehealth. Just kind of roughly, what percent of claims now for DNR telehealth? I mean, how does that compare to where things were before the crisis?
Well, I am not the first nor the only to say the following. And we saw telehealth advance 5 to 10 years in about a month in the spring of 2020, and that will likely continue on a wider basis and accepted by more as we move into the future. At the peak of our telehealth volume in late spring and through the summer of 2020, we had about 30 to 35,000 members using telehealth in some capacity each month. That has stabilized through 2021 at about 18 to 20,000 members using a month, telehealth in some capacity a month. But that is about 4 to 5 times more what we were seeing in any given month pre-pandemic. So telehealth is here to stay. It's ideal for those non-emergent situations that we all understand: conjunctivitis, ear infection, sore throat, sinus infections. And it's proving to be ideal for those who have had difficulty accessing the behavioral health system and behavioral health providers, not just through an access perspective, but with the burden and the weight that the pandemic, the change in our work environment, as Krista and Vaughn mentioned, and just the heaviness that the pandemic has placed on all of us. Accessing the behavioral health system and behavioral health providers is and will continue to be crucial for the foreseeable future. And telehealth has proven to be a very efficient and effective mechanism through which that can occur. And then also, we're excited to see that that telehealth is providing some venues for those in more rural populations, of which is very important to those of us here in Wisconsin, and also those who have social determinant barriers, which whether they be transportation or feel uncomfortable or can't afford taking time off work to see their provider. Telehealth will provide a viable option for those situations, both now and into the future. So I see it being a fundamental component to how care is accessed and delivered as a result of what we've seen coming out of the pandemic.
Thanks, Les. So Les, to encourage this continued growth of telehealth, there's a push here in Wisconsin and other states to require that insurance companies cover and pay the same for telehealth as they do for in-person services. Does that make sense to you? I mean, is that something that Dean Health Plan would support? Well,
it's a conversation worth having. We certainly will acknowledge that providers likely have some technology and infrastructure investments to make to ensure that they provide the best telehealth experience for their patients. On the flip side, we believe that net it is a more efficient and more affordable way to provide access to care, and whether or not it has an impact on the overall brick and mortar footprints of providers, I think remains to be seen. So I think it's a good conversation to have, but our expectation is that once things stabilize and settle out, I would anticipate for care provided through behavioral health or through telehealth to be a more affordable and more cost-effective way than in-person settings.
Thank you. Vaughn, what do you think? I mean, what impact would would coverage or payment requirements have on costs? I mean, you think it's fair for insurance companies to pay the same for telehealth as in-person visits?
Well, at WA, we have been proponents of telehealth early on, and I agree with the comments made previously that it's particularly useful in behavioral health and other areas. We saw a doubling of our registrations on the traditional telemedicine side and astronomical growth on the behavioral side for all the reasons that Les mentioned. I think there are some cautionary tales to observe in the process, though. I'm pretty much a fan when I go to the doctor, if I can do it virtually and not have to stand on the scale, that's a success for me. That doesn't mean it's delivering the best healthcare in all settings. And so during the pandemic, I had 2 preventive cardiology visits where all they could do is ask me about my prescriptions. And what we've seen, at least at WA, is that there is no price break on the kind of services that are offered. And we have to ask ourselves as a community, is it worth the same for a cardiology visit to be talking to your doctor on the phone than it is to actually have the diagnostics performed in the office? And I think there's a discussion that can be had there as well. So I'm open to and support expansion of telehealth. I am a little less enthusiastic about it in areas where it may not be the best for the patient, and we should have a conversation about it. And there's a conversation to be had about relative value in terms of if it makes sense to spend that kind of money on every service. Is it a solution to every type of healthcare need? No. Is every type of telemedicine appropriate for every type of need? No. And so having some restrictions on it might make sense.
So for those services that it is deemed appropriate, in these initial stages, as telehealth is ramped up, and Vaughn, I'll stay with you on this one. Some have argued that it at least makes sense to pay more in the beginning to help pay for this infrastructure that is going to be need to put in place as things ramp up. I mean, is that fair to, some states have required, have put in place payment parity with a sunset of let's say 5 years as they study the impact and allow the infrastructure to be built up. I mean, is that a fair compromise or a fair way to look at this?
Well, I get that there are likely some expenses that need to be incurred to develop it. We've seemed to have established that now and are frequently using it. Our participation rates are quite high. And it's, we've seen some change in practice where providers are still billing for facility fees on top of the service, even though you're not in the office. I don't know how long that should continue under the protection of legislation versus the normal contracting process. So again, I'm open to it. Anything that we can do to promote for our members accessible care is great. I think we like to have some control to make sure they're the right services with the right providers for the right outcome. And we're open to the conversation.
Great. Krista, what about, sorry, Paul, did you want to add something? Okay, Krista, what about some of the remote patient monitoring tools that don't always fall under the traditional definition of telehealth? How are you handling that as an insurance company? And what kind of future do you see in that type of care?
Yeah, I think there's going to be a lot more conversations. We do have a, kind of a hospital at home type program, which there's a ton of remote monitoring that goes along with that, but that's part of a bundle, right? So we're not talking about a specific instance. So there's going to be, I think, a lot of work on the contracting team side to figure out what is the right way to, and the appropriate way. Again, I think there's going to be infrastructure build. I think there's going to be, sort of provider incentives needed initially to get them to kind of use it, to get to an optimal point where then it really does become lower cost. But I don't think, sort of out of the gate, you can necessarily pay less because they're not yet efficient at it. The other thing I just wanted to mention, Les brought this up briefly, but I think it's a really important, whenever we're talking about, digital, whenever we're talking about telehealth, that rural perspective does become really, really important. And I think it often gets lost because, everybody just thinks, you got cell coverage all the time. And there are parts of many of our service areas, right, that don't have consistent broadband access. And so there's a bigger infrastructure build need that needs to always be part of that conversation until there is consistent sort of statewide coverage. If you think about the areas that don't have consistent broadband, they're probably the most rural, right? The most in need of additional care and easy to access care. These are the same people that have transportation issues. These are the same people that are going to struggle to take time off to get to an appointment. And so that really has to be kind of a key part of the conversation, and thinking not just about sort of telehealth or sort of digital health in terms of direct to consumer, because it's not an option for everybody, but how can we build it in, smaller satellite centers? How can we build it so it's as convenient as possible, but in a way that actually is dependable for the user, and they can actually get through and have that appointment.
Thanks, Krista. Paul, under a new federal rule, insurers could eventually be required to provide information about consumers' out-of-pocket costs for certain, quote, shoppable services. Some of the deadlines for this rule have been delayed, but how is Anthem preparing for this, and what impact could this have, do you think, on transparency?
Yeah, no, thanks for the question, Tim. Anthem's been preparing, obviously. I think, one thing, and I think it's probably consistent in the market, and Anthem's invested. You talked a little bit about technology earlier, right, with telehealth and other modalities of care treatment. We talked a little bit about, remote monitoring devices and the likes. And a lot of times when we think about those types of services and you hear new technology, you think new costs and more costs. It doesn't necessarily need to be, the case. We can frame that up as, hey, what a unique opportunity we have in front of us collectively to ultimately drive some costs down by using technologies that didn't exist yesterday. The same applies, frankly, to transparency. Transparency isn't new to our industry, right? We've had transparent tools available, whether it's cost and quality tools in different modalities, whether it's over the web or through applications and the like. And I think the new technologies like AI and we talked about Anthem's Health OS platform to help try to predict and control costs through some transparency that's available today that wasn't yesterday will be good for everybody. I think part of the challenge with what we're seeing today, and this will evolve over time, but under the scope that's out there today, and part of the challenge that exists today with a finite number of data compared to where we will be in the future is that it needs to be customer centric. It needs to be user friendly and actionable. Otherwise, all the data and information in the world is really not going to do much for anybody. I think we agree with that. So the scope we think is a little large today. It doesn't really narrow in on true shoppable opportunities for members and consumers to truly analyze information that will be available and make proactive decisions based on, what's best for their own personal health, what's best for their own personal financial situation, and weigh the cost quality metrics. So that's one of the challenges. I think it's just trying to boil the ocean out of the gate. So we're advocating for narrowing a little bit to make it more user friendly. And we think that will go a long way. Other than that, we think having a more proactive approach on price transparency should be a positive thing for consumers. Will it solve all problems? Probably not, but it's a step in the right direction for sure.
So thanks, Paul. Can you just expound on that a little bit? I mean, what are specifically some of those ways that this could be improved to get to this goal of transparency and having an impact on decreasing costs?
Yeah, I mean, the way the reg is set up today, it's there's this massive scope of these machine readable files. They need to be there's requirements, and part of that has developed to be the backbone behind these cost comparison tools, right? But a lot of what's in there, as the industry is so complicated, and each individual health situation is very unique. You have to continue to understand that there's information that may be out there that's not necessarily relevant. And if it's not that relevant, then how useful is it going to be to those that try to get to the end and goal, which is to improve shoppability, consumer engagement, and create transparency to drive people towards quality, high value care. If it doesn't get to that end, then it feels like it's just a lot of extra, and we need to really create focus on that scope. It can always be expanded in the future, obviously, as the technology and the data improves. But I think starting with a level of services that are quote unquote actually shoppable is the right place to start.
Thanks, Paul. Vaughn, what do you think about this rule? What impact do you think it will have? And are there specific ways you think it could be improved?
Yeah, I think that support the purposes for which it was created. I guess I'm having difficulty seeing how the regs as they've been promulgated will deliver on any of those. We've seen on the provider side in their transparency rule how provider systems, each and every one, slices and dices based on network and product design in a way that isn't really credibly available for the public to digest in any meaningful way. And I think the same will be true on the insurance side. It's going to add cost and complexity. A much narrower focus with more clarity, maybe some standardization along the way to make sure that you're really comparing apples to apples and that it's actually in a format consumers can use would be a start. But at this point, I think that it's solving a political problem and not a healthcare problem.
Thank you, Vaughn. Krista, we all know that healthcare costs are going up. What do you think is the biggest driver of healthcare costs? I mean, what meaningful steps do you think could be taken to address costs?
Yeah, so so Vaughn, I don't know if you knew this when you made the actuary crack, but I am actually an actuary. So this one is near and dear to my heart. So right now what we're seeing in terms of cost drivers are surprisingly, I think, outpatient services. So we're seeing more office visits, we're seeing more ER, more kind of standard care than kind of what we've seen in the past. And then, of course, prescription drugs, which I believe has been a cost driver for the last 10 years, at least, maybe longer than that. But as we look at it, it's not utilization. We talked a little bit about that earlier. It's actually on the unit price side. So we're seeing an increase in acuity, a higher need for care. So instead of a level 1 office visit, now it's a level 5, say. And I do think this connects back to the delays in care, right, from 2020, at least to some degree. People were not getting diagnosed early. They weren't in for preventative care. And now, so now we're treating condition rather than truly having the preventive piece. And then on the prescription drug side, it's specialty meds that continue to be the driver. We see more and more migration to, higher cost specialty that really is significant. I think, when I first started in healthcare 13 years ago, prescription drugs were consistently about 10% of spend. Now it's getting really close to 15%. And continuing to edge upward. So that's definitely an area, and I know we're all focused on, I'm sure, how to manage that spend. What I see as opportunities, there's a lot we can do, and there was a lot of this actually in the initial comments around community engagement. So rather than having it come from insurers, I really think there are some, a lot of partnerships between, our members, our providers, our community organizations around community health, because we got to really get at the starting point rather than sort of treating the illnesses. We need to sort of focus on building healthier communities as a way over time to reduce the healthcare spend. Something that we, have spent a lot of time here within our system on, doing community assessments, kind of what are the things that are driving the social determinants, right, that are driving some healthcare spend for us. And we see ABCs, so alcohol and drug abuse, continues to be sort of a high area. Behavioral health. So again, comments on access, but they're a big deal, right? Because there's a high need and growing need related to behavioral health, and then chronic conditions. So diabetes is one, again, where we continue to see from a condition perspective increase and drive more costs. So how do we get more on the front end and start to build it rather than just dealing with it on the back end?
Les, what do you think? What do you think is the biggest drivers to healthcare costs right now, and what can insurance companies do to play a role in decreasing costs?
I concur with Krista. Drug costs and specialty drugs seem to be the primary driver over the past several years. We're doing some things within Dean Health Plan such as careful formulary management. We provide personal assistance with Navitus, our wholly owned PBM, for members who have complex medication regimens, and also working with our employed pharmacists to help members identify cost-saving alternatives. Yeah, I'm not an actuary, but I will, one of the things that is the case and has always been the case is not just unit costs, as Krista mentioned, but the volume. So a couple of things that we're looking at are a heavy investment and commitment to population health. If helping people achieve healthier lifestyles, nutrition, life activity, taking care of themselves, goes back to the old adage, an ounce of prevention is worth a pound of cure. That remains true today. More services result in higher costs. And if we can help people help themselves in achieving healthier lifestyles and achieving their desired health state, that's good for everyone. And then secondly is also, in addition to health and wellness, but then overall population health management. So more services result in higher costs. More intensive services also result in higher costs. And as Krista mentioned, and others have, diabetes is, when it's managed in a chronic state, is much more effective for the patient at a much lower cost. It is the definition of a win-win. When it gets out of control, it escalates exponentially and becomes much riskier for the patient, and as a result, at a much greater cost. Similarly, around preventative screens, colorectal cancer screenings, breast cancer screenings, childhood immunizations, time and time again, those have proven to be very effective at ruling out incidents of disease, but then resulting in early detection, in which the health outcome and the clinical outcome is much greater, and it's achieved at a much lower cost. So health and wellness and population health management are things that the health insurance industry has been committed to for the last 10 or 15 years. And we at Dean Health Plan will remain committed to it because, again, it comes back to that whole adage, we believe an ounce of prevention is worth a pound of cure.
Paul, a group of bipartisan lawmakers introduced legislation last week backed by hospitals and other providers that prohibit insurance companies from requiring that clinician-administered specialty drugs be purchased through certain specialty pharmacies. They argue that this process, sometimes referred to as white bagging, could interrupt patients' care and pose safety issues. How do you respond to that? As we talk about healthcare costs and specialty drugs has been brought up a couple of times now. How do you respond to this legislation and the impact that it could have?
Yeah, I think the legislation was just introduced. I can't comment specifically on those, what's on the table today. But as was just noted, I think by Krista, the actuary, and Les, that one of the biggest drivers that we're seeing is on specialty meds. It's something that is it's a somewhat skyrocketing part of the overall cost equation, and we need to be able to address that to continue to offer access to affordable care. When you look at some of the medications that that fall into that bucket, these cost tens to hundreds of thousands of dollars per dose even. And this is, across the country, we're seeing, a similar dynamic. And, there's a situation where, you can have a reasonable markup and a profit level for some of those costs and the drugs themselves. And not only in addition, the administration of the drugs themselves, but the cost of the drugs themselves needs to be addressed. I will say this though, Tim, again, getting back to, I think, the collaborative kind of get it done nature of the Wisconsin healthcare marketplace is that, most of the health systems in the state have worked with us specifically to address that particular issue, and have agreed to address the cost equation. So I think to the specific legislation, I think it's still early. We have to monitor it, but something clearly needs to be done to address the skyrocketing costs there.
Krista, what do you think? I mean, how common is so-called white bagging by insurance companies? What kind of impact would legislation like that have?
Yeah, so I think there's sort of mixed usage. Being part of an integrated delivery system, certainly have maybe a little bit of a different perspective on this than others. But when you step back and think about the issue that's at hand, right? It's what can be safely done outside of the four walls, and more care across the board. We're finding can potentially be safely done as long as you have sort of the right patient safety and quality lens in place. So I feel like this is, I know this is a specific topic, right, that's really relevant right now, but, stepping back and saying, this is part of that lowest cost site of service conversation, right? And we're doing hospital at home, we're doing SNF at home, we're doing all kinds of other things, home infusion for years and years. But it does come down to, it's not going to work for everybody. It's not going to be safe for every patient. And how do you find the right balance of a program that really has that quality and safety lens as the center for the decision making?
Vaughn, what do you think?
I have general agreement with the comments made that more and more services can be performed in the home safely, and that the cost driver related to specialty drugs are real. What we didn't emphasize, and I think is important though, is that the practices of requiring white bagging or requiring site of service is an increasingly rare situation. Never happens in our plans. So in one respect, it's a bit of a solution in search of a problem. I think where I have more significant concerns though is the scope of the legislation that goes after PA and other utilization management tools that have really proven to be significantly important to our members, not just from a cost perspective, but from a care perspective. We have innovative cancer programs where a lot of these specialty drugs are administered, and our experience shows that double digits in terms of percentages of people with diagnoses of cancer are either misdiagnosed or misstaged, which fundamentally changes the appropriate course of care that they're going to receive, their outcomes, and potentially the costs associated with care to get them well. And so if you're going to take those tools away from us to partner with our members to get them to the best possible care that saves them money and gives them the best opportunity for outcomes, you're actually averse to the goals you've stated for the legislation. And I think that kind of a discussion needs to happen. It's too easy to just make this a bad practice and call it white bagging and not look at the details that are going to affect the outcomes people are expecting.
Thanks, Vaughn. Krista, federal lawmakers are pushing to make permanent increased ACA subsidies to make these subsidies permanent that have been provided temporarily by the American Rescue Plan Act. What would this mean for insurers participating in the ACA individual market? I mean, what kind of impact would this have on the overall market?
Yeah, so I think, first and foremost, I think this is really great for what it does for affordability of coverage, right? For the individuals who have to participate in this market, it creates a lower cost, more affordable option for them over time. And so there's stability for both the membership and for the plan, which I think is a really good thing for the ACA market, to the extent that we can continue. And Wisconsin has been fairly stable. I think one of the more, Paul could probably comment, nationally, probably one of the best states for a stable market. But there's always opportunities to improve the stability, and it helps for planning for both, again, the plan and the individual to know that, their costs are not going to be significantly increasing year over year because the subsidies are going to help moderate that, and really continuity of care, right? So they know they're going to be able to have coverage again next year. And so they don't have to hurry up and get sort of every service done this year, that they're going to continue to have it year over year. So I do think it's a tremendously important thing to be talking about, and certainly support a permanent fix for it, just for that stability.
Les, shifting gears a little bit, with the federal health emergency set to potentially end at the end of the year, what impact could that have on Medicaid enrollment? I mean, what are, from a Medicaid side of things, what's being done to prepare for that?
Well, certainly once the public health emergency expires, we anticipate that DHS within Wisconsin will resume the established practice of looking at enrollments and Medicaid enrollments and membership based on eligibility and changes in circumstances. And the net result of that is likely that we're going to see a fairly large number of Medicaid beneficiaries roll off Medicaid. So we are working with Director Jones and Department of DHS and others to achieve the same goal, which is that joint goal is to ensure that no one goes without care, that everyone is able to maintain care. So we're beginning to develop messaging, communication strategies, as well as options. So when that occurs, whenever it is, and it's still somewhat speculative as around when the public health emergency expires, but anticipating that to be sometime at the end of the year or 2020, early 2022, is to communicate and to engage with those Medicare beneficiaries so that they can transition to quality and affordable care and not be disrupted through loss of coverage.
Paul, Wisconsin remains one of the most competitive states in the country for insurance. What is Anthem doing to stay ahead? I mean, what are some new partnerships or areas you are exploring?
Yeah, whether it's what we just talked about, whether it's Medicaid and public health redetermination, eligibility determinations, or Medicare, or individual commercial products, whether on exchange, off exchange, group plans. I mean, Wisconsin has one of the most robust marketplaces, hands down, regardless of what segment you're looking at. So that's a value. I would say that in and of itself, it gives a lot of choice to consumers. And it gives a lot of competition amongst the plans and provider systems. So that's all positive, I think, for the Wisconsin consumer. From Anthem's perspective, we talked a lot about digital earlier. We're investing heavily in digital capabilities. Like any other business, when it's something new, you have to make front end investments for the equation for long-term savings. So we think that the digital investments that we're making today and have been making are going to have a significant impact in the products and the price points and the affordability that we can bring to the marketplace. So we have products available today, and those will only continue to expand in the coming years. I think one of the other things you talked about cost earlier, Tim. There's a little discussion about utilization and unit cost. I think the focus was more on unit cost, and I think we have to continue to have the conversation about paying for value, regardless of what modality that care delivery comes through, whether it's a virtual telehealth service through a chat format or whether you're sitting in a hospital or a SNF. We have to continue to talk about how we shift the dialogue from paying for volume and paying for value. So most of the contracts and the spend that we have across the state is through a value-based program. And I think those are fundamentally to ultimately shifting the cost curve, continuing to create affordability, and trying to continue to innovate with care providers out there.
Paul, and what impact has the pandemic had on that, on this movement towards paying more for value?
Yeah, I think it's interesting because it's a really big topic. It covers a lot of things. There was, I think the silver lining from my perspective, day in and day out on the pandemic, has clearly been around the light that's been shed on social drivers of health. We talked a little bit earlier about how, telehealth has played an important role in that. I think Les referenced behavioral health as being an important topic relative to that. We're seeing utilization in telehealth on behavioral health specifically at a higher rate. And we view that as a very good thing. There's a social stigma around gaining access. There's a transportation issue in certain cases, and there's just an access issue generally speaking across the state. So I think sometimes, more is not less, right? And sometimes having more care at the right place at the right time, under the right cost structure with the right incentives in place is what the doctor ordered. That's what we need to do more of. And I think the conversations that I have with the health systems across the state, they are fully aligned to that idea. And I think we're moving much more rapidly towards that continuum. And I think the pandemic is actually, quite frankly, give us a little bit of kick in the rear side where we needed it and focused us to do the right things there. So I'm very bullish and optimistic about those conversations as we move forward here.
Thanks, Paul. Vaughn, WHN Trust has expanded statewide with Health Tradition. How is that going? What's driving growth for your plan? I mean, where do you see the biggest opportunity for further growth?
Yeah, for most of our 50 years, we were a niche player in the public employee sector, operating as WHN Trust. And now for the past 3 or 4 years, we acquired Health Tradition Health Plan, which has given us the opportunity to kind of jump into the private sector, an area that we otherwise had not been a part of. And we're now in more than 52 counties around the state, introducing ourselves, and have seen real pickup in terms of membership. In recent years, we are out with some new cost share alignment plans that, getting to Paul's point, try to steer people to the value providers and to invest in them early to reduce costs, and that has been well received. It is a competitive market. There's no doubt about that. I think we're bullish on the future just from the standpoint that we can take the good work we've done for 50 years in the public sector that's been well recognized and translate that into a product or a series of products that will be available to the private sector from small group to large group. And stay tuned. There are good stories to come.
Great. Krista, as Marshfield Clinic Health System continues to grow, security is growing along with it, entering these new markets, including potentially crossing state lines in the near future. How has that gone for security? I mean, and if Marshfield goes to the UP, does the security go into a new state with them as well?
Yeah, certainly, the way that it's kind of been happening over the last several years as Marshfield Clinic has expanded, Security Health Plan has followed in many cases. So the expansion into Dodge County is probably the best example, right? The health system purchased the facility in Beaver Dam, and then, we were able to follow shortly thereafter with some products. So certainly, it's a benefit of being a part of an integrated health system. However, we also know that you have to have a network, which is more than one facility, right? And so that becomes a really important part of the conversation. Multi-state, though, is, a whole different ballgame. And so, we're still understanding, and I think in some ways we've really been spoiled. I mean, Wisconsin is a great state to operate in. And so thinking about how, Michigan is going to be very different. Their regulations, their requirements, just for licensure, could take multiple years. And so it's having the patience, right, to kind of step through each piece of the process and know what's the right rollout for what line of business and what makes sense. The UP population looks very similar to the rural northern Wisconsin population, so we feel comfortable that we know how to serve them. But it is the dynamic of going from one kind of primary regulator that we feel like very comfortable, we know very well, to now having another one in the conversation. It's going to be a big change for us.
Sure. It'd almost be easier if it just was part of Wisconsin, as maybe it should be.
But is it too late to get that changed?
So another important provider partner of security has been Aspirus. And as Aspirus grows and places a new focus on its own health plan, what does that mean for security and that relationship in the northern part of the state?
Yeah, so, certainly on the provider side, we compete, and on the plan side, we compete. But Aspirus has been and continues to be one of our strongest provider partners. And I don't see that changing, from the plan's perspective. They do a great job on population health. They're really engaged with us on quality discussions. They're a go-to partner in many spaces for us. And so, we continue to value them, and I believe they value us. I think we're a pretty significant payer for them. And so managing through, again, it's a competitive market, so you could pick on any one of us to say, I'm sure we're all crossing over into different payer provider arrangements as part of the competitive nature of the state. And I actually think, it makes us all better, right? Because we're competing on both sides and we're learning from what the other entities are doing well.
Great. Les, Dean Health Plan has already crossed state lines and is looking for growth opportunities linked to SSM Health. Just briefly, how is that going, and what's next? What are maybe future growth opportunities specifically in Wisconsin?
Sure. It's going really well, Tim. We remain deeply committed to South Central Wisconsin and our core Dean Health Plan service area. Of course, we have a 7-year partnership and relationship with Prevea Clinic and HSHS in the Northeast and Northwest part of the state. And that has seen substantial growth over that 7-year period. And we're launching Medicare Advantage products in Eau Claire and Chippewa counties for 2022. We're really excited about that. And as you mentioned, and as Krista referenced for the security in Marshfield situation, our strategy and vision includes expanding our presence in serving members where SSM has a care delivery footprint. We are covering lives in Missouri, Illinois, and Oklahoma, primarily through our employee health plan, but then also Medicare Advantage and individual ACA. And we expect over the coming years to expand products into those markets and partner with SSM to bring service and the value that comes from an integrated care delivery network, an integrated health system and health plan, along with our PBM relationship with Navitas, to bring value to the populations of Missouri, Illinois, and Oklahoma, just like we have served Wisconsin for the past 39 years.
Great, thank you, Les. So we have quickly ran out of time, but with the few minutes that we do have left, I was hoping to get one last question for each of the panelists, hoping that each panelist could answer this last question. So eventually, hopefully, we will be in a place where COVID-19 has settled down and is not as dominant a part of our lives as it continues to be. As insurance companies begin to navigate this new world, and we've talked a lot about this over the past hour, but what will be some of the biggest trends impacting the industry? Les, we'll stick with you, and if you had to just pick one or two, going forward, what are going to be the biggest insurance industry trends?
Two that come to mind off the top of my head, Tim. First is what does the future of the workplace look like? So our workplace and culture as well, but the workplace and culture of our employer clients as well. It's certainly that challenge is not unique or specific to health insurance. We are all going to face that to some degree, where people live, where people work, and how they access care. And it was mentioned earlier, but the second thing that comes to mind are what are the long-term cost implications of COVID? I'm not sitting here today as either a clinician or a data scientist, but it's just hard for me to believe that there won't be a longer tail in terms of clinical impact of deferred care and avoided care for the better part of 18 months. We don't know what that's going to be, but it just feels like that is something we're going to be living with for the next several years.
Great, thank you, Les. Vaughn, let's go to you. In the years to come, what do you think are going to be the biggest issues facing the insurance industry?
I think clearly the digital engagement side of the house is going to be where we see a lot of new interventions, new opportunities. and a new culture that are going to really hit us as a direct result of what we went through with COVID.
Great, thank you. Krista, what do you think?
So I'm going to second Les's comments on workforce. I think that's going to be a big challenge. And the other one is, and I think this is always a concern, is government regulation, right? So you brought a few topics up. That's always out there. You know, we're a heavily regulated industry, and never knowing kind of what the next thing is that we're going to have to be managing through.
Thank you. And Paul, what do you think? What are going to be the biggest trends facing the industry in these next years to come?
Yeah, thanks, Tim. I don't know if it's facing the industry. I view it as, maybe I'm the overzealous optimist, but I look at, coming out of the pandemic, again, addressing social drivers of health, the light that's been cast on, food insecurity, transportation, maternal health, behavioral health, you name it. That is a huge opportunity. And, getting back to, I think, was said earlier, is leveraging technology to kind of connect the system more effectively, drive affordable access to care, and simplify the system over time is, I think, where we're headed. That's where the puck is going. It's leveraging technology, increase affordability, increase quality, and address the underlying social drivers that have been looming for a long time. I can speak on behalf of Anthem. That is topic number one on addressing those issues, and we're not going to lose sight of that goal.
Great. Thank you, Paul. Thank you all for really a great and wide-ranging discussion. We appreciate your time. Thanks to all of you for tuning in, and thanks to our generous sponsors for making today's discussion possible, with an extra thanks today to UnitedHealthcare Community Plan. Thank you.